Hello, and welcome to today's webinar, Empowering Nurses to Protect Themselves and Their Patients, Examining the Role of Environment and Infections Across the Continuum of Care. My name is Kate Wiedemann, and I'm a Health Communication Specialist in CDC's Division of Healthcare Quality Promotion. The mission of CDC's Division of Healthcare Quality Promotion is to protect patients, protect healthcare personnel, and to promote safety, quality, and value in both national and international healthcare delivery systems. This webinar is part of a series of infection control-related webinars that CDC will be hosting with the American Nurses Association and members of the Nursing Infection Control Education Network. Before we get started, I want to go over a couple of things. So to hear the audio, please ensure your speakers are turned on with the volume up. The audio for today's conference should be coming through your computer speakers. We welcome your questions. Please submit any questions or comments you have via your chat window located on the lower left-hand side of the webinar screen anytime during the presentation. Questions will be addressed after all presentations as time allows. To ask for help, please press the Raise Hand button located on the top left-hand side of the screen if you need to chat with a meeting chairperson for assistance, for example, for technical difficulties during the webinar. Also, the speaker slides from today's presentation will be provided to participants in a follow-up email. I'm going to go over a little bit about our continuing education for this webinar. CDC offers a variety of continuing education credits to various healthcare professionals as outlined on this slide and the following slide. We would also like to bring to your attention that all of the speakers who are presenting on today's webinar have disclosed no conflicts of interest regarding this presentation. And this slide here outlines the objectives for this presentation. Slides and instructions on how to obtain continuing education will be emailed immediately after today's webinar. Now I'm going to go ahead and introduce our three speakers for this webinar. Monica Escalante-Colbuck is a Senior Associate at the Institute for Quality, Safety, and Injury Prevention at the Emergency Nurses Association. Our second speaker is Sarah Delgado. She's a Clinical Practice Specialist with the American Association of Critical Care Nurses. And our third speaker is Ellen Jones. She's an infection preventionist at Community Rehabilitation Hospital in Indianapolis, Indiana. And now I'm going to turn it over to Dr. Sean Ross at the American Nurses Association to give us a quick introduction to today's webinar. Dr. Ross?
Thank you, Kate. My name is Dr. Sean Ross, and I am the Director of Nursing Practice and Work Environment at the ANA. As the world becomes more global, the potential to spread infectious diseases across the countries increases. Outbreaks within the last decade have pushed healthcare organizations to examine existing practices, accountability mechanisms, and staff training. However, the healthcare industry's readiness for the next emerging infectious disease relies heavily on healthcare providers' understanding and adherence to infection prevention and control protocols. As the premier organization representing the interests of the nation's 3.6 million registered nurses, ANA understands and appreciates the impact of nurses in these processes. ANA recognizes that nursing practice intersects with nearly all healthcare settings and that nurses are key in transforming health and healthcare. At any given time, about 1 in every 25 patients has an infection related to their hospital care, which roughly costs about $26 to $33 billion annually. In addition, antibiotic-resistant germs cause more than 2 million illnesses and at least 23,000 deaths in the United States. Sometimes an overlooked component in infection prevention and control, the environment is a natural reservoir that poses an inherent risk to the patient, clinical staff, and visitors. Today's webinar is the third webinar within the NICE Network series, Empowering Nurses to Protect Themselves and Their Patients. Today's webinar will use a case study to discuss the relationship between the environment, the patient, and patient outcomes across the continuum of care. At this time, I'll turn it over to Monica Colebrook with the Emergency Nurses Association.
Thank you for having me. I'm delighted to be presenting on behalf of the Emergency Nurses Association. The emergency department, often seen as the heart of the hospital, can be a stressful place to work with increasing numbers of patients with varying acuities and case mix. It can be considered a high-risk area for disease transmission because EDs can often be overcrowded, and infectious or susceptible patients may wait in close proximity to one another for hours. Patients not only have the potential to spread diseases to staff and other patients, but they too are vulnerable to acquiring new infections associated with the care they receive. So therefore, infection prevention remains a major challenge in emergency care. Using a case study, we'll be walking you through the three practice environments: the emergency department, the critical care unit, and rehabilitation. As we go through each of these environments, our goal is to discuss disease risk recognition and demonstrate the various factors that influence and impact a patient's health, including features specific to each of these environments that may influence disease transmission. So why don't we go ahead and get started. So you can imagine you're in the emergency room right now, and the radio goes off and the EMS report begins. Good afternoon, General Hospital. This is Unit 25 coming to your facility with an ETA of 10 minutes. We're bringing to you a 55-year-old male, alert and oriented ×4, from a local nursing home with a fever, sore throat, cough, and general malaise. He has no known allergies. He is on a list of medications, which we'll be bringing along, and has a past medical history of diabetes, renal disease, a recent hip fracture from a fall, and CRE. Vital signs are BP 156/82, pulse 96 and regular, respiratory rate of 22, and pulse ox reads 92% on room air. He's not in any respiratory distress. We have initiated oxygen 2 liters via nasal cannula, and stats have increased to 96%. His blood glucose is 115. The patient currently does not have any other complaints. When we listen to the EMS report, they are very quick. Probably no longer than about 45 seconds. And in that time, an ED nurse needs to listen for key signs and symptoms. So the EMS report we just heard should raise a couple of red flags. First, we should already be thinking about some sort of infectious process going on. So is it from the recent surgical wound? Could it be something else the patient might have caught in the nursing home? Or what about the patient's medical history? So what do we know about CRE? CRE infections are associated with high mortality rates and have the potential to spread widely. The rapid spread of CRE has made these organisms a particularly important target for prevention. So detection is and protection is really key. One of the most vital steps in preventing further transmissions in the ED is rapidly identifying those who are infected or who may be at risk, and placing those patients on the necessary transmission-based precautions as appropriate. So the nurse needs, so the nurse knows that this patient has a history of CRE and immediately should start thinking contact precautions. One of the biggest factors in the emergency department is that knowledge of whether a patient is infected with a pathogen is rarely known at the time they actually present to the emergency department. So often we have to go on empirical evidence to initiate transmission-based precautions to help prevent the spread of disease. So keep in mind that in the emergency department, it's a major gateway to inpatient care, contributing to nearly half of all hospital admissions. Risk recognition and making decisions are often done with limited and evolving data under significant time and even resource constraints. The emergency department also serves as a frontline response to any public health emergency or disaster, and given this diverse role, infection prevention can be easily overlooked or superseded by other immediate and life-threatening issues. In this scenario, as with any, the charge nurse has to really evaluate the entire environment of the ED and consider the most appropriate placement for this patient. In this case study, the charge nurse is able to place the patient in a private room. She wheels over an infection prevention cart and places it in front of the patient's room and puts a contact precaution sign on the front of the door. In addition, the charge nurse has flagged the electronic health record and communicated with environmental services and registration to let them know that the patient will be on contact precautions. So all of these steps are additional measures that can easily be implemented to help reduce the risk of further disease transmission. So even though the emergency department can be pretty unpredictable, there are things that we do and we can control. The protection of infectious disease exposures in the ED requires a combination of safety and health controls. So what I mean by that, the first are like training and administrative controls, such as infectious policies or transmission-based policies and procedures, and screening tools. What's important here is training and education, including hands-on practicing like donning and doffing personal protective equipment. Second are engineering controls. Most people may be more familiar with negative pressure rooms or airborne infection isolation rooms, and these are used for patients with measles or tuberculosis. Third are work practice controls, and that's something like what we demonstrated before, the use of signage on patient doors indicating the transmission-based precautions that's currently being used. And lastly, but of course not least, is personal protective equipment. Going back to our case study, so we know the patient has a known history of CRE, and the nurse anticipated initiating contact precautions. But also the patient has been actively coughing, so a combination like droplet precautions were initiated until further diagnosis could be ruled out. So while contact precaution includes gown and gloves, masks were also added for additional precautions. So first and foremost, hand hygiene is a primary factor in preventing disease transmission, and every effort should be made to promote good hand hygiene. Some key points to remember about contact precautions is that it includes full coverage of the arms and front of the body from the neck to the mid-thigh or below. So while caring for patients that require contact precautions, like our case study, the ED nurse needs to remove the isolation gown and gloves before leaving the patient care area to prevent possible contamination of the environment outside of the patient's room. So isolation gowns should be removed in a manner that prevents contamination of the clothing or skin. So the outer or the contaminated side of the gown needs to be carefully removed by turning the gown inward and rolling it into a bundle and then discarding it into a designated container. Communication is also important. The emergency nurse really needs to make sure that environmental services and other ancillary staff are aware of the patient's status, so that if there's anything like contaminated waste, they can ensure that proper disposal is done, as well as disinfection of the room. So when nurses are caring for multiple patients, there is always an urgency to don or doff, which also could potentially cause transmission concerns and even self-contamination. So a critical point to remember is that even in the emergency care setting, it's important to take time to appropriately don and doff PPE. Let's talk a little bit about some opportunities for contact transmission in the ED. So what are some other opportunities for further transmission? In any practice area, not just the emergency department, hands of healthcare personnel are the greatest concern. Germs on our hands may transmit pathogens if hand hygiene is not performed correctly before and after patient care. So CRE are spread when the bacteria are transferred through touch. So for example, a nurse may touch the wound or stool of an infected patient and then go ahead and touch another patient, infecting the second patient with the bacteria. So these bacteria can also spread by touching a contaminated surface, such as a medical tool or a hospital bed. It's unclear for how long the bacteria can remain alive on surfaces, so it's important to work very closely with environmental services as well as infection preventionists to determine the appropriate cleaning measures. Patient care devices are also opportunities to pass on disease. Devices like Devices like thermometers or glucometers may transmit pathogens if devices are contaminated with blood or body fluids and they're shared between patients without cleaning or properly disinfecting them. In the emergency setting, running from room to room, grabbing devices without cleaning them in between patient care can lead to disease spreading. Other objects we provide patients, such as remotes or call lights, can become vehicles for transmitting pathogens. So it also may be necessary to limit visitors depending on the situation. So it's important to review individual hospital policies and guidelines and for more guidance. So going back and looking at our case study, let's talk about what interventions would take place in the ED. First, the patient's brought in by paramedics, and the primary nurse and the charge nurse are waiting in the room, gowned and gloved, to receive the patient. They've initiated contact precautions, and ancillary staff comes in to perform the bedside registration. So you probably have an ED tech who also walks in to assist with setting up the patient. So while registration is in progress, you have nurses are receiving a report, a handoff report from EMS. So the staff will place the patient down, they put the patient on the monitor, establish baseline vital signs. The nurses will probably initiate some oxygen while the tech is probably taking an oral temperature. After completing a full set of vital signs, the ED tech goes to write down the vital signs on a piece of paper, and he realizes he doesn't have a pen, so he may borrow one from one of the nurses. Their nurse, makes a note that the patient's currently febrile. In addition to setting up the patient, the nurse begins to start a secondary IV and draw blood, including a first set of blood cultures. As the staff is working on settling in the patient, the nurse notices that the patient's coughing with a productive sputum, so she should probably start thinking that they may need to call respiratory therapy to get a sputum sample. Environmental services happens to walk in to check the wastebasket and see if the garbage is full. The primary nurse will notify them that there's no need at this point to change the garbage. As staff is completing their initial assessment, a physician walks in, gowned and gloved, and introduces himself and begins the history and physical, and gets a little bit more suspicious about a potential infectious agent. The patient appears to be stable at this time and is only complaining of some lethargy. So a CBC, a CMP are ordered, including blood cultures, a lactic acid, urinalysis, and chest x-ray. The primary nurse hands the patient the call light, and all the other staff doff their PPE correctly and exit the room. So a lot went on in that limited amount of time there, but what's really important is who entered the room. So all of these people, from the primary nurse to environmental services, all of these individuals walked into the room as the patient was being dropped off by EMS. And each of these individuals can play a critical role in transmitting further disease, but they also play a major role in preventing disease transmission by taking the proper precautions. So let's talk a little bit about what could have gone wrong. And in fact, a lot of things in this scenario could have gone wrong. Perhaps staff could not have performed proper hand hygiene, or devices that were used could not have been cleaned in between patients. Inanimate objects could have been taken out of the room into other patient rooms. Remember, the ED tech needed a pen to write with, so what did he do? He asked one of the nurses to borrow a pen. What if he happened to be writing with his gloves on, and he could have potentially transmitted pathogens via the pen? Maybe the charge nurse then took that pen and handed it to an immunosuppressed patient to sign discharge papers. Or what about other devices, like the computer in the room or the keyboard? Maybe the nurse might have used it for charting and she left her gloves on. Or what if the nurse next door, which happens often, is yelling out for help and staff runs over to help and they fail to doff their PPE correctly? So the issue of environmental contamination poses a great challenge in the emergency department. There are several risk factors for infections, and the biggest and the highest standard of measures for infection prevention can't always be addressed due to impelling life-threatening conditions. However, identifying which sites are more frequently contaminated in any practice environment could play a major role in infection control practices and promotion of new interventions. So what happens next in this case scenario? Blood work comes back, and the patient's chest x-ray was positive for pneumonia. So we start antibiotics, and respiratory therapy had come down, obtained a sputum sample. Because the lactic acid was elevated and the patient appeared to be having increasing respiratory distress, including his extensive medical history, a critical care consult was obtained, and the patient was being prepared to transfer to ICU. The ED nurse goes ahead and calls the ICU nurse and provides a quick background of the patient's medical history. They discuss interventions that were completed and the level of urgency of the patient's condition. The nurse provides the ICU nurse with anticipated plan and asks her to follow up with any pending labs. The patient's then prepped and ready for transport to the ICU, and a combination of contact and droplet precautions were initiated during transport. The ED nurse then notifies the charge nurse of the disposition of the patient and also informs environmental services to clean and disinfect the room. No other patient was placed in that ED room until it had been thoroughly disinfected. So as we transition care from the ED to the ICU, I too am handing off to my colleague, Sarah Delgado, clinical practice specialist with the American Association of Critical Care Nurses. So Sarah, I'll hand off to you.
Thanks, Monica. This is Sarah Delgado with the American Association of Critical Care Nurses, and I'm going to be picking up this patient as he is admitted to the ICU. So upon admission, based on the report from the ED, contact precautions are initiated in the care of this patient. Unfortunately, he quickly decompensates within the ICU environment with oxygen desaturation, and he is unable to maintain an oxygen saturation above 88%, even with 100% non-rebreather mask. He has tried on non-invasive mechanical ventilation, but he is not able to tolerate it, and a decision is made to urgently intubate the patient for airway protection and hypoxia. And as you know, whenever you have an urgent procedure taking place, you generally get a crowd coming to the room. There's the team that's coming to perform the procedure, and also sometimes people who come to observe or learn from the experience. And it's very important to remember that even in an urgent situation, contact precautions should not be overlooked. Though it would be easy to say that the patient's risk for respiratory failure supersedes the need for contact precautions, in reality, if there are healthcare personnel, the nurse or respiratory therapist in the room providing bag mask ventilation to the patient, then the team coming to intubate the patient can take the 30 to 40 seconds that it takes to gown and glove before going in. Certainly anyone who's arriving on the scene to observe or learn from that situation should be expected to gown and glove. Fortunately, in the situation of our case study patient, the charge nurse, who is assisting the nurse with the urgent intubation, stands near the door of the room and reminds people as they enter he's on contact to trigger them to comply with the contact precautions. So what could happen if the charge nurse did not take that action and contact precautions were not adhered to in this urgent situation? Well, the anesthesiologist who comes to intubate the patient, her next move is to go to the PACU and round on fresh post-op patients. So potentially she could transmit CRE to that setting and cause a devastating postoperative infection. Similarly, if the nurse documenting the urgent intubation moves the bedside computer next door without cleaning it, well, that's another fresh post-op patient who's at risk for a devastating postoperative infection. If the physician who attends the urgent intubation leaves the room without performing hand hygiene and uses the unit telephone, then now the wider ICU environment is contaminated with CRE. The respiratory therapist similarly could contaminate another room if after the intubation his next move is to round on other patients who are on a ventilator. So going back to our patient, our next step, now that he's stable on the vent and sedated and his oxygenation is stabilized, the next step is to establish a diagnosis. Because of the history received from EMS and from the emergency department, a rectal swab is done to confirm the presence of CRE. And on hospital day 2, we confirm that the patient has carbapenem-resistant Escherichia coli. His sputum culture, which was taken during his stay in the emergency department, shows strep pneumoniae. So what does this mean? Well, it's kind of good news because he has a very treatable pneumonia. We have a lot of antibiotics that can treat this very common organism. The bad news is that he also has CRE. So what is CRE? Well, CRE, or carbapenem-resistant Enterobacter is an infection that is resistant to our strongest antibiotics. You see on this slide that it requires very high minimum inhibitory concentrations to kill bacteria with this resistance. So it's a dangerous organism because it doesn't respond to the treatment tools in our toolbox. Some patients who are at risk for CRE, the highest risk factor is those who have undergone frequent or previous antibiotic use. We know this patient was in the healthcare environment previously and was probably on antibiotics. In addition, patients who are chronically ill, who have a prolonged hospital stay, who have multiple admissions or are immunocompromised are at higher risk. Indwelling medical devices such as endotracheal tubes, central lines, urinary catheters are also an increase in risk. Any disturbance in gastrointestinal function, particularly if patients are NPO and not receiving enteral feedings, that raises the risk for CRE. Patients who, like our case study patient, come from long-term care settings are also more likely to carry CRE. So what we know about CRE from for this patient, we don't believe that this patient is infected with CRE. He's infected with the strep pneumoniae. That's the cause of his symptoms. However, he is colonized with CRE. It's growing on his skin, and he has it. What does that mean, colonization? Well, we don't need to give him antibiotics to treat it. That's the good news. However, he can be a reservoir and a source of infection for other patients on the unit and for our ICU. So we need to think about this impacting his care and how we're going to protect our unit from this dangerous organism. So why do we worry about CRE so much? CRE was listed in 2013 by the CDC as an urgent public health threat. And the reason for this is that when pathogens develop resistance to the treatments in our toolbox, then they have a greater risk of causing fatal sepsis, even in patients who are otherwise healthy. We also know that if we can attend to this problem adequately now, we can have fewer problems in the future with antibiotic resistance. So careful and meticulous attention to CRE may prevent the next antibiotic-resistant organism from arising. So the next steps with our case study patient, after he's intubated, his family arrives, and the nurse notifies the family that he's on contact precautions. The family replies with, "We know all about that, we've been with him, and we haven't gotten sick." And what this statement demonstrates is that the family may have need some education about the purpose of contact precautions. On the following day, the patient develops acute kidney injury, and he begins intermittent dialysis because he is hemodynamically stable. The following day after that, he undergoes a spontaneous breathing trial, which shows that he is not ready to be extubated yet, that his respiratory status has improved, but he's not ready for extubation. So basically what this means is that we know he's going to be with us for a few days. He's not going to be in and out of the ICU quickly. And during the time that he's with us, what can we do to mitigate the risk of his CRE colonization contaminating our environment? Well, as Monica explained, first and foremost, we need to attend to hand hygiene. We need to attend to hand hygiene and contact precautions. And just a quick review of the steps in contact precautions. Hands need to be washed before putting on the gown and gloves or using an alcohol-based hand sanitizer. Then gown and gloves are put on before entering the patient's room. Gown and gloves are removed before exiting, and hand hygiene is repeated before exiting the room. Additional steps that we can take to reduce the risk of contamination are to ensure that the contact precautions are followed consistently. If some people are donning and doffing appropriately and others are not, then we still have a high risk of contamination. Posted signs and verbal reminders, such as the nurse gave during the urgent intubation, can go a long way in ensuring the consistent application of contact precautions. In addition, as nurses, we can think about how we organize our care and the impact that will have on contamination risk. If we can bundle our care to minimize our trips in and out of the room, that can make a difference. I don't think anyone comes to work and is excited to find out that their patient is on contact isolation. It's an extra step, and it feels like it takes extra time to go in and out of the room. So the fewer the trips we can take in and out of the room, the more time we save, and we reduce the risk of contamination, because fewer trips means fewer opportunities for CRE to be carried from the patient's room out into the ICU environment. One trick that I learned was to stand outside of the isolation room prior to donning gown and gloves and ask myself, do I have everything I need for all I will do? In that way, you can ensure that you've gathered all your supplies and you're not having to take the gown and gloves off, go back out of the room, and start all over again. When we think about the particular case of our case study patient, we have some other risks besides the nurse going in and out of the room. There's the family going in and out of the room. There's other members of our ICU team, the respiratory therapist, the dialysis nurse. In addition, we have equipment, as Monica mentioned, that can be a vector for contamination. The patient is diabetic, so a glucometer will travel from this patient's room to the bedside of other patients. The dialysis machine will go from this patient's room to other parts of the hospital. Any diagnostic equipment, such as an ECG machine or ultrasound, will also be used repeatedly with other patients. So some other considerations given these additional risks are that the healthcare team has an obligation to explain the risk of contamination and help the family understand the purpose of contact precautions. Of course, members of the healthcare team want to adhere to precautions not only to prevent contamination, but to role model the importance of this intervention. In some instances, hospital protocols will dictate the use of disposable items, so those can save some time and also prevent the risk of contamination. A blood pressure cuff or a pulse ox probe that can be used and then thrown away at discharge will prevent the in and out of the room that carries the risk of contaminating the ICU environment. Equipment that I mentioned, the ECG machine, the glucometer, should be cleaned according to individual manufacturer instructions, but in general, equipment should always be cleaned after it is used on a patient who has who is on contact precautions, and then allowed to dry before it is used on another patient. One approach to take with the family that might be helpful, in addition to helping them understand the purpose of contact isolation, would be to seek their partnership in the implementation of this intervention. So have the family ask staff or remind people going in and out of the room to perform hand hygiene and wear gown and gloves. In this way, we can have a team approach, and it doesn't feel punitive when we're asking them to adhere to precautions. What could go wrong if these steps were not taken? Well, honestly, maybe nothing. We really can't quantify the risk of contamination with CRE in this situation. And we know that in some cases, people will be exposed to CRE and not become infected. But we also have to think about who is in that ICU and who is in the larger hospital environment and how people move around. And think about if the patient next door is post-transplant, that patient's infection or exposure to CRE could lead to an infection that is life-threatening. What if there's a rapid response call in the oncology unit and the staff on the ICU are called to assist with that? What if the dialysis machine is not cleaned and the elevator becomes contaminated? Or the patient's family leaves his bedside and goes to the cafeteria without performing hand hygiene. And now they've placed CRE on surfaces that are very remote from the patient and highly trafficked by other members of the community. So when we think about it and think about the breadth of potential consequences of failing to adhere to contact precautions, that it's really the impact of a preventable infection becomes a preventable death with this kind of virulent infection. We want to wonder, is the risk of spreading CRE to others worth the time that we save if we cut corners in contact precautions? So back to our case study patient, he improves during his stay in the ICU. The ICU staff are vigilant and adhering to contact precautions, and the patient weans from the ventilator. He undergoes daily sedation interruptions, spontaneous breathing trials, and progressive mobility. He continues to require dialysis, but he is successfully extubated. So what are the next steps for this patient? Well, he's going to move to another site of care. He's not well enough to go home. So there's going to be a transition to another site of care. He needs to get stronger. In addition, we need to communicate with environmental services about the management of the room he occupied. So in report on a patient who is colonized with CRE, it is essential to include that patient's risk of contaminating the future environment. This is the kind of information that should be part of every report, along with the patient's age and the patient's code status. You should include the fact that he is colonized with CRE. It's important to remember that the CRE is not going to go away. This patient is going to require some form of contact precautions in all admissions to the hospital, though those precautions will vary based on the setting they're in. And Ellen is going to go over how contact precautions are used in acute rehab in just a moment. The second step we need to think about is how we handle that room that the patient was in and get it clean so that the next occupant is not exposed to CRE. Routine cleaning focuses on high-touch areas, but terminal cleaning, when the patient is discharged, needs to address all the surfaces in the room and a change of curtains. We know that curtains can harbor infections that survive on surfaces. A good trick is to leave the sign that indicated the patient was on contact isolation in place until the environmental services team has cleaned the room. And when we think about, this is the room after the patient is discharged, and when you look around this room and think about all the different services that CRE could be surviving on in this room before the next patient arrives, it really brings to light how important the work of environmental services is and how we need to partner and support their efforts to ensure that patients are not exposed to high-risk pathogens like CRE. I'm going to pass this on to Ellen, who's going to go over the care of this patient as he transitions to acute rehab to get stronger and continue his recovery.
Thank you, Sarah. I'm Ellen Jones from the Community Rehab Hospital in Indianapolis, and my collaborator is Mary McCord from St. Louis. Happy to be with you today and be part of this case study. So what is a day in rehab like? And I'm asking you that question because I'm guessing that most of our audience does not know. But the answer is active. Every patient has to meet a minimum of 3 hours of therapy each day, 5 days a week, to qualify to stay in acute patient rehab. There are skills groups in addition, like cooking. There are education groups like stroke and brain injury and spinal cord injury. There are medical care needs. They don't actually qualify unless they're still needing 24-hour nursing and physician oversight. So our physiatrists, which are physical medicine and rehab physicians, see the patients, as well as an internal medicine physician. We have site consults, and of course we're doing the usual nursing care. In addition, however, the patients don't eat in their rooms. They go to shared dining rooms and they sit together. And family are very important because they have to learn how to care for their patient once they go home. So they're going to be going to therapy sessions. They're going to be practicing in the room and in therapy. They may go to meals, meeting other people that are there, getting acquainted. So this whole scenario is quite a different animal for infection control because you have so many opportunities for the environment to be playing a role in the spread of infection, not only inside the room, but outside the room. So we got our nice, safe handoff from ICU. We knew about the patient even before the nurse-to-nurse report because we have liaisons that work up the potential admissions for us, and then they share those details with the admission office, and CRE would have been put on the admission notice that goes to all staff. The house supervisor would have looked at that admission notice and reviewed that patient and assigned a private room and beginning of contact precautions. Now, in our particular facility, we do use contact precautions for CRE and ESBL, but that is not true in every acute inpatient rehab hospital or in other long-term settings, and that is supported by the CDC CRE toolkit. So we have to look at our risk of, by our region, by our facility, and by the individualized patient risk of spreading CRE as we make that decision. If they are continent, have no lines, no wounds, are able to provide much of their ADLs independently, then they are so much less likely to spread CRE as long as they do their good hand hygiene. So our ICU nurse then calls with the nurse report just before the patient comes, and we get our diagnosis and the story about the vent and that he's off now. We're going to have to set up for dialysis, and we're going to have to see speech as well as OT and PT. So we also see the CRE colonization, and that has been confirmed by a recent rectal swab. We will have to attend to his diabetes. So the house supervisor gives the direction that we'll be using contact precautions for this patient. So we put our sign on the door. It's a very explicit sign, which we designed so that patients, families, caregivers, and all of the contractors that might be coming in would be having the information they need. So the sign is also placed in the patient room on the little bulletin board there so that the family and the patient can also review that and keep in mind what is required. Communication of precautions is just absolutely key to carrying it out in our setting because the patients are generally not in their room in the daytime. They're everywhere else. They're in the dining room, they're in therapy, they're in the halls. So you have to make sure everybody knows what we're doing. Okay, so the admission notice lets the therapy scheduler mark contact precautions on the therapy patient schedule. And that is primarily how therapists know that that patient is on precautions, because there are transporters that pick up the patient and take him to therapy. Nurses mark precautions on the safety huddle sheets. That's what nursing uses, and in the electronic medical record. Then we use emails daily to keep everybody updated that needs to know, including respiratory therapy, the case managers, housekeeping facilities, the kitchen. Everybody who needs to know gets informed so that they can see where we are and how we're working to get everybody out of isolation, or if they'll have to stay for the duration. In our setting, they will stay in contact precautions for the duration of the stay because we have had a local reservoir of CRE in the Indianapolis area. So we are working very hard to remove that. This is our little handy-dandy chart for the way we do precautions in our setting, and you'll notice that the top yellow line is a reminder that patients have to perform hand hygiene when they leave the room. So it's not only our hand hygiene that matters, because patients and families are going throughout the building. They have to do the same hand hygiene we have to do when you leave the room or go into the dining room or go into therapy. The staff that's overseeing them needs to make sure that hand hygiene is being done by the patients and families. So the patient arrives. Of course, it's 10:30 on Friday night, which is actually pretty typical for us. That's our highest admission time. So we have our contact precautions already. And so the nurse and the tech, they're already wearing their PPE, get them admitted and get their vitals done, do the assessment. Meanwhile, they will use the sign to help the patient and the family understand what precautions means for them. So they have to understand their hand hygiene requirement when leaving the room. They have to understand that they don't need to wear PPE just to sit in the room. But if they're going to physically be helping the patient and touching their linens and so on, then they would want to put on the PPE, then remove and do hand hygiene. And the next time, get a clean gown. So we need to show them where the gowns and gloves are, and they actually are outside every room in the linen closets in the hallway. We don't have any carts, but everybody has access to PPE at any time if they're doing something that could splash. And we also need to show them how to get in and out of those gowns appropriately. So who else is going to be coming around? We've got probably more contracted caregivers than what you would have in an acute hospital setting. So they can spread germs not only here in our building, but also to other buildings. So we have to make sure that they are on on point with us. So that's our physicians, and our internal medicine physicians come from the hospital, so they're rounding in the hospital all day, and they take turns coming over to see our patients. So it's a big variety of those. We have ambulance services because if we need anything such as any kind of radiology test or so on, or a feeding tube placed, we actually have to transport them to a hospital. So we see the EMS folks all the time. Our respiratory therapist, our portable radiology service. We don't have an x-ray room here, but we do have a portable chest x-ray machine. So those techs come from the hospital and use our machine when we need a quick x-ray. Our PIC team is contracted, our dialysis team is contracted, and our wound care people are contracted. So we've had to train all those folks and make sure, and that's part of why our signage is so explicit. Now, the environment is just a huge part of safety in rehab. So you can see here our dining room, and it is a shared dining room. You've got on the two left pictures, you can see a variety of tables where patients are sitting, and so that's why patient education and patient hand hygiene before they come into the dining room is so key, and there is a provision for that right at the entrance to the dining rooms. And then for nursing care, you have to be a lot more flexible in our setting. This nurse is actually sitting on the bed while the patient is doing a respiratory treatment. We do not have much respiratory therapist coverage, so our nurses do the primary amounts of respiratory therapy. So here she's giving an aerosol treatment, but she's also going over the education, and she'll be giving meds. You can see her computer on wheels there. Now, she put a barrier gown on the bed so that she could sit down. This patient is not in isolation. I actually saw this nurse in the room just a couple of weeks back, so I said, well, I'm going to add that picture. Look at that. So she thought about, I want to sit and be eye to eye with my patient when we're talking, but I want to protect myself and everybody else, so she did not contaminate herself by doing that. Of course, she will need to decontaminate that computer on wheels as she leaves if anything has been touched in the room, and with her hands, so she'll definitely need to do at least the keyboard. In the bottom right picture, you'll see a patient who's in one of the therapy gyms, and there's an occupational therapist there. He's the gentleman with a headband. And then our nurse, who's bent over to scan the armband to give a med, she had to track him down. He was in therapy. So the therapy schedules are a big part of our work because you can't always get to all the patients while they're still in the room. Because most of the time, if you've got 6 or 8 patients, they could be anywhere in the building. So you have to go track them down. But the same precautions apply in terms of decontamination after you use any equipment, including the computer on wheels, with any patient. We do have therapy dogs, and so on your left there, that's Bullet. He is an extraordinary therapy dog, and he really helps patients look to their affected side if they are having neglect on one side, and they're also providers of comfort to both patients and staff. They do not go to isolation patients, and there are strict rules about how animals and pet therapy happens in our setting. Now back to our case study patient. They're going to stay in contact precautions for the duration of the stay. Again, that's in our setting because we've had a reservoir of CRE here. The electronic medical record gets flagged with the CRE date and the details. They are going to go to therapies after using the alcohol foam. The therapist will use PPE as needed to prevent direct contact. And they're going to go to the dining room. We're going to back up one point. If they are going to go to education groups, and if I decide, I'm an infection preventionist, that they can go to skills group, they always ask me on those so that I can evaluate that patient and see what we would need to do. to let them go to a skills group or if it's not safe for that patient. So we dedicate equipment to the room. We disinfect anything that goes between rooms. We ask the physicians to use the disposable stethoscope, but they also have to track down patients in therapy sometimes. So then we have them use the appropriate wipe, disinfectant wipe. If we're going to do dialysis, it'll be in the room, and then that equipment will be disinfected. We educate the family, and then if we're transferring, we disclose that CRE colonization to the next facility. EVS is a primary player for us, and they daily clean those rooms with particular attention to all the high-touch surfaces, and they do the terminal cleaning at the end. We leave the site up until they take it down. We do not have curtains, which is a real blessing. If we did, they would need to be changed, the cubicle curtains. So what happens if we do it wrong? Hospital-acquired infections may result. And if we have poor intermittent cath techniques, so we're doing that since the Foley was removed in the ICU, well, they're going to end up with a UTI possibly. If they didn't get the Foley out, or if we didn't get it out, or if they still had a central line and we didn't get it out, they could end up with either a CAUTI, catheter-associated urinary tract infection, or sepsis. Poor and injudicious use of antibiotics and ineffective sanitation in rooms of patients with C. diff can spread C. diff to more patients. If we didn't follow contact precautions or standard precautions, we can spread CRE to other patients and staff, and we can actually build our own reservoir of CRE in the unit, in our staff, in our patients, in our environment. If ICU didn't tell us that the patient had CRE, or we don't disclose it to the next facility, we actually could be the cause of an outbreak of CRE infections, and they are very serious infections. Nursing removes the precaution sign before EVS cleans. If that happens, then they may or may not do the terminal cleaning with the correct chemicals. So that's why we always leave the sign up, and the EVS takes it down. We don't take down signs in nursing. The worst outcome would be multi-system organ failure or even death if they end up if we end up spreading CRE, carbapenem-resistant Enterobacteriaceae. So we made great progress with our patient, and he's not quite ready to go home yet. He was here 9 days. He's now up to walking 200 feet, gaining independence. He's off supplemental oxygen except at night. So we call the nursing home where he'd come from originally, and he'll continue his therapy there, and we disclose that the patient has CRE. So we are ready for our patient to move on to the next facility, and they're out the door. I will now hand off to Dr. Sean Ross.
Thank you so much, Ellen. We've heard a great wealth of information today during our webinar examining the role of the environment and infections across the continuum of care. The 3 key points discussed were: 1, nurses in all healthcare settings play an essential role in protecting patients and themselves from multi-drug-resistant organisms. 2, transmission-based precautions are an effective strategy for protecting patients, healthcare providers, and the community from multi-drug-resistant organisms if consistently applied. And 3, organizations of care and communication across healthcare settings impacts the risk of environmental contamination. So now we move into the question and answer portion. And the first question that I'm going to pose to Monica from the Emergency Nurses Association is: how often does EMS actually report a past medical history of multi-drug-resistant pathogens?
That's a good question. It really depends because it depends on where the patient comes from. If they're coming from a long-term care facility or some sort of other healthcare facility, typically we're given the information from their handoff report that the nurses end up giving EMS. But for the most part, if you have a patient who just happens to trip and fall outside, given the immediate emergency, they one may not remember that they have a history of something, or two, it's just something that they absolutely forget to list and to tell you about. Maybe they don't think it's that important. So I guess at the end of the day, it's not really often that we're told ahead of time. And that was one of the key points I wanted to make, was that often in the emergency department, we're the last ones to find out about some of their history.
Thanks, Monica. I'm going to ask the next question of you too. In the setting of unexpected high volume, such as a mass casualty event, where triage is so important, what are the ways in which infection control principles can still be maintained?
So this interesting question, as we've seen like a lot of incidents that have occurred recently, like the Las Vegas shooting, most major incident programs follow specific phases of response. So when there's a disaster surge, disaster plans should cover immediate delivery of PPE to like the triage area. If the mass casualty incident is inside the hospital, such as an emergency department, then preparedness is really key. So you're talking about staff drills for an event, and that's also going to include your infection control staff. In fact, usually we drill and have one person who's designated as the infection control preventionist. Some other key things to remember during mass casualty is really the care that you give is going to try to be as close as possible given the resources and supplies that you have. So personal protection protocols and equipment are still going to be important. Prophylaxis protocols may be necessary to treat the healthcare workers. You're going to look at trends and of what types of patients are coming in to see if there's anything that you may be suspicious of, but really you're using your empirical evidence to help plan for those for potential infection issues. Ongoing education is key to success in reducing the incidence of infection during a disaster. So the groundwork for success is going to be laid out long before the disaster strikes. And really it's the practicing of the drills that's going to be helping out during a situation when, during like a mass casualty or something like that.
All right, I'm going to thank you, Monica. At this time, I'm going to turn it over to Kate.
Thank you, Dr. Ross. So before we end today's webinar, I just wanted to give a little bit more information about continuing education. So you must complete the continuing education post-test and evaluation. Please follow the detailed instructions that will appear on the post-meeting webpage right after you close out of the webinar. You must complete and pass the post-test activity at 80% to receive continuing education. For those on the phone who currently aren't logged into the ReadyTalk platform, to obtain continuing education, please go to www.cdc.gov/TCE-online. The access code for this webinar is EVS1025. A follow-up email will also be sent after the webinar with detailed instructions about completing the continuing education post-test and evaluation. With that, I'd like to thank our speakers, as well as all of you, for taking the time to join us today and for your commitment to keeping your patients safe. Thank you so much. This concludes today's webinar.